Well, welcome to the roundtable. I'm so excited for you to be here with us to share your story, to tell us a little bit about your work. So if you'd like, the floor is yours. Go ahead and introduce yourself to our guest. Let us know what you do, and we'll start from there.
Great. Thanks so much for the invitation, Casey. I really appreciate it. So my name is Heath Hightower. I have a master's degree in social work since 1998. I also have a Ph.D. in counseling psychology. I've been a clinician since 1996. I am currently an assistant professor of social work and equitable community practice at the University of St. Joseph's in West Hartford, Connecticut. So that's a little bit about who I am.
So a little bit more about like the work you do and maybe how you got to the point where you're now teaching, whether it's your origin story and work or what you're passionate about.
Yeah, so my origin story is kind of interesting. I had grown up always believing I was going to be a lawyer, that I was going to be a corporate lawyer, that I was going to spend most of my times working for a multinational company, doing mergers and acquisitions and making a gazillion dollars. And then my junior year of high school, actually, I was diagnosed with cancer, Hodgkin's lymphoma, and that really kind of changed my trajectory. So while I was diagnosed and I had my first rounds of treatment my junior year, it was really a 3-year journey of cancer. And so by the age of 19, my freshman year of college, I ended up having a bone marrow transplant and actually finished um, my freshman year of college from a military hospital bed. And it was really during my time in that hospital experience that I had really started to rethink, like, how did I want to spend my life after treatments? Um, and so part of what was really interesting about that transformation is that many of the skills that you need to be a good lawyer, like listening, being a good communicator, being able to make a compelling argument, those are the same skills that we need in human services. It's just, I didn't really think about it in those terms until that point in my life. So after that, I really decided that instead of, being a poli-sci major and an econ major, I decided I was going to be a psych major. So I ended up studying psychology as an undergraduate. Um, really loved that experience and thought I was going to be a psychologist. And it wasn't until I had gotten back from a service learning trip, which was my junior year of college, where I spent a significant amount of time living and working in a Romanian orphanage. And it was that experience that really made me think about how I wanted to spend my days. So, I was a psych major. So the only thing that I knew about being a psych major was being a therapist, and that I was going to spend my entire day like sitting in a room with, probably individual clients and doing therapy. And that's kind of what I thought I would be doing. And after that experience in Romania, that didn't sit as well with me as I thought it was. I felt like I needed to do something more kind of public, something more out in the community and not behind closed doors, so to speak. So I got back. I started applying to graduate school, and I just applied to PhD psychology programs. And I was actually pretty naive about that process because I thought I would be able to go right from my undergraduate experience right into a PhD program, skipping a master's degree altogether. So I was a little naive about that process. So it wasn't until after I had submitted all of my applications that I saw a little flyer on the graduate school bulletin board for the Boston University School of Social Work program. And I was reading the flyer and I thought, that sounds kind of interesting. So I tore off the little card and I sent it in. And about a week later, I got all of the propaganda from the BU School of Social Work and read through it and fell in love. And what I really fell in love with is that the BU School of Social Work really prided itself in balancing a clinical education with a more macro kind of community organizing education. And both appealed to me. Obviously, the person that I was who wanted to be a psychologist was really interested in the clinical stuff, but I was also interested in this whole policy part, this community organizing part, this advocacy part, which had been a part of the lawyer that I had always wanted to be. So there was this bridging of those two parts of my personality and of my interests. And I ended up applying and ended up going and ended up, flying across country and moving to a city where I had no friends and no relatives, and spent 2 years at the BU School of Social Work getting a really, really great education. Um, and that's kind of what really launched me into social work as my primary professional identity. Much, much later in life, so when I was in my mid 40s, I had had a really long and varied clinical career. And I had been doing some adjuncting, and I also had been able to secure a couple of full time teaching jobs without my PhD. But those jobs were going to become few and far between, especially if I ever wanted to do something um, kind of higher in higher education. So, literally at age 45, I decided to go back and get my PhD in counseling psychology. And I chose a really particular program that really focused on social justice research. So the PhD that I have is actually not a clinical PhD, but rather kind of a research oriented PhD with a real focus in kind of critical theories and qualitative research. That was really the focus of that PhD. And so that really kind of leads me to where I'm at now. So professionally now, I still identify as a clinical social worker. I do still practice as a clinician, but I'm also engaged as a qualitative researcher. My focus has really been on suicide in multiply marginalized communities. So I've been really focused for the last 2 years on suicide in Black and African American communities in the United States. And I think I really love both being a clinician and a scholar because that really informs what I do in the classroom. Um, I'm a pretty practical person. So while I like theory, theory to me is only helpful if it helps me and helps my students help other people. I'm not interested in theory just for the sake of theory. So I really love the classroom because the classroom is really the place to really bridge practice and theory and research. And so that's how I spend most of my time now.
So, between the projects that you do and the teaching, what would you say is some of the work that you find is progressive and very important to the human services field?
I'm really focused on suicide in multiply marginalized communities. And I think suicide is still one of those really big taboos that really carries a lot of stigma in our culture in particular. I think that most people think about suicide and people who are contemplating suicide. I think most of us think of those kinds of people in really negative, kind of pejorative and stigmatizing ways. So I'm really interested in talking to people who are thinking about dying by suicide, and people who also carry with them marginalized identities, and also, I think, pushing back on kind of our popular discourse about suicide. So, just as an example, most of us, when we think about suicide, is we think about that as being primarily driven by mental illness. So, depression, anxiety, bipolar disorder, borderline personality disorder, etc. And the truth of the matter is the epidemiological research, as well as just the statistical research just doesn't bear that out to be true. While it is absolutely true that about 45% of people who die by suicide would have been diagnosed with a mental health condition, it's also true that 55% would not have been. And so I'm actually really interested in that 55% of suicide and suicidality that doesn't have anything to do with mental illness at all. I'm also really interested in, and again, I think there are lots of people who are doing a lot of great work in suicide prevention. But I think the statistics are also bearing out that whatever it is that we have been doing, it's not working, right? We're still seeing pretty high suicide rates across the board. But again, even in more marginalized communities, we're really seeing those numbers increase. And so for me, the interesting question is, why is that true? And what, if anything, can we do about that? I would also say that there is another population of people within cohort of people who contemplate and attempt suicide who never seek treatment at all. And so that to me is really interesting. So what is it that's keeping people from seeking out support and assistance with their suicidal thoughts and or behaviors? And what we know from the research there is that people are afraid of being hospitalized. They're afraid of being what I like to call medically incarcerated, where their personhood, their autonomy, their rights to self-determination are really curbed. And so I think the projects that I'm really interested in moving forward are, what are some alternatives that people who are in fact experiencing suicidality, what would they be willing to engage? I think it's pretty clear that nobody wants to be hospitalized, but what do people want? And, when I look to other countries and what other countries are offering and providing, I'm actually really inspired by that. I think our friends in Canada, our human services colleagues in Australia, and in other parts of the world, they're really doing some really innovative things where they are working collaboratively with people who are actively suicidal, who want to end their lives, working hand in hand with them to try to establish some alternatives to hospitalization. We're not doing that here in the United States at all. We still pretty much prefer the incarceration method when it comes to suicidality. So those are the kinds of things that I'm really interested in. And again, I think human services should be leading the way, because as a profession, historically, have been really comfortable framing really all problems in systemic terms, in ecological terms, and thinking about both assessment and intervention in those lights as well. And so I think that we could be leading the charge in this particular area.
What are you seeing as, I guess, the major differences and approaches between what we do in the United States and what other countries like Australia and Canada are taking on? Part of me says it's probably like something to do with the ego of the culture. Is that close?
Yeah. So I think part of it is in our culture, we have a real top-down model where people who have like expertise that is based on a credential, we really steer those conversations about what we're going to do, right? As opposed to a more bottom-up approach, whereby starting with people who have lived experience and really centering their experiences, experiencing their voices, centering their expertises, and working hand in hand with them to build something that might actually be helpful. So I think in other places, that is happening much more readily than it is happening here. Um, I also think that we have a very prevention oriented model here, which is fine. But one of the problems is in our culture, we have a zero suicide mentality, whereby any suicide that occurs is viewed as a failure. And I think suicide is really complex. It's been complex across cultures. It has been complex across time. In some cultures against oppression. In other cultures, there are honor suicides where people take their lives um, in the name of securing their honor. In other times, suicide has been viewed as a crime against the crown or against God. Um, and so the idea that suicide is any one thing, I think, is a real problem. And interestingly, I think leads to an all or nothing kind of thinking um, that we as human services folks would often want to help our clients fix, right? We oftentimes would want to help our clients get out of an all or nothing mentality. And yet, most of the psychosocial professions in the United States really believe that all suicides have to be prevented, and any suicide that occurs is really viewed as a failure. Um, and I think that the truth is I know people, I have colleagues who are chronically suicidal, who still get up and go to work every day. They wouldn't meet the diagnostic criteria for a mental health condition, and yet there are no spaces for them to talk about their lived experiences. Because if they did, and they did it in front of a licensed mental health professional, they might be hospitalized against their will. And so I think we need to think about our responses to suicide more on a continuum. And yes, there are probably lots of suicides that could be prevented. And the ones that could be prevented, we should do a better job of preventing those. But we also need to recognize that suicide is complex and that there is always going to be a percentage of people, even if it's a small number of people, who will always want to die, regardless of how much therapy we give them, no matter how many times they are hospitalized, no matter how many milligrams of drugs we pump into them. And we need to create spaces for them to get their needs met too. And we currently really don't have those spaces. So I'm thinking that's the kind of work that I am interested in. Yes, prevention where it is helpful, but also expanding the spaces for other lived experiences where prevention may not be the appropriate framework to address that.
It sounds like the perception of suicidality in our culture, it's a failure if it happens. It's almost like a treatment of you failed at the American dream, or it plays against hyper individuality, where if that's the end all be all case for an individual, okay, well, we obviously failed in getting them on board with that ideal. And it's so deep in our culture that to fail that it's immense. It has been for centuries, right? So can you talk a little bit more about the bottom up approach that you're seeing in other countries and what maybe we're doing here that resembles that?
Yeah. So I think so I was just in touch with a colleague from Australia recently, and his job, he works for a national health organization. He himself is someone who chronically lives with suicidality. So in our culture, we oftentimes elevate the voices of people who were previously suicidal but no longer are. And again, those are important voices who should be included in our conversations. But in Australia, they're going a step further. They're going a step further by including people who are still actively suicidal, and those people are being given jobs in the realm of suicide support services. So, just an example, there's something called a suicide sanctuary, where instead of hospitalization, um, it is a physical space where people who are suicidal can go, and those places are professionally serviced by people with lived experience, right? So it isn't necessarily people with PhDs in psychology. It's not necessarily, nurses and doctors. It's people with lived experience who have been who in a process of what we call accompaniment. And that work is actually comes from another friend and colleague of mine, Alexander Burrill, out of Canada. This idea of accompaniment really echoes what we talk a lot about in the United States, which is starting where your client is and being with them. But what accompaniment means is you are with a person throughout the entire journey. And in our culture, we're comfortable being with people until they disclose that they're suicidal. And then we can't wait to get them out of our offices and then send them to somebody else who will be responsible for keeping them safe. Um, and accompaniment is different. Accompaniment is leaning in with curiosity into people's suicidality and not trying to convince them not to be, not trying to invalidate the reasons why they might want to be, not trying to persuade them to believe that they, in fact, have a life worth living for, when in fact they may not. But accompaniment is really about being with people and being with them for the long haul, no matter what comes out of their mouth, no matter what they disclose, and not punishing people for that. And again, in our culture, we frame hospitalization as us keeping somebody safe. But that's not how people who are hospitalized think about it. They don't think about us as people who are keeping them safe. They think about us as people who are incarcerating them, who have taken away their rights to self determination. And we've now made it more likely than ever that they won't re engage services again. We've also now increased the probability that people will continue being suicidal, but they will do so in complete isolation and alienation from other people, which for a social species is the worst possible thing in the world. So accompaniment is really about showing up and keep showing up, as opposed to what we do in this culture, which is we show up conditionally. We talk a lot about theoretically about unconditional positive regard and unconditional, but we place a lot of conditions on people. We're only willing to work with you if you're willing to stay alive. And there's something really cold and kind of anti-human services about that. So other countries are doing this sanctuary accompaniment process in a way in which we are not doing that at scale.
So with that kind of ideal in mind and that practice that you're seeing other your colleagues doing, what step or what purpose, what part do human service professionals play in making that kind of change in the way that we are, conditioning folks to do a certain thing or giving them ultimatums to their own life?
Yeah, I think where we really have to start is with our own professions, right? So part of what guides our practice is our own codes of ethics. So in our codes of ethics, we have this thing called a duty to warn and a duty to protect. What's interesting about those duties is that the same duty I have to a client, if a client says that they're homicidal, which is to say they want to kill somebody else, is the exact same duty I have as if someone says that they'd like to kill themselves. To me, that's really different, because somebody saying that they want to kill somebody else who doesn't want to die, we should stop that, right? Like, that is something that we should intervene on. That to me is very different than someone who is saying, you know what, based on the life that I have, based on the things that I've tried to make my life better, I don't want to do it anymore. To me, that's a really different, those are two really different things, yet we treat them as identical, right? And so I think we need to, and by the way, homicide is a crime, right? Like, homicide is a crime. But by placing suicide and homicide within our codes of ethics as being essentially the same in terms of how we are supposed to respond, I think that's a real problem. And it then, of course, doesn't open up the possibilities to professionally behave differently, right? So right now, it would be impossible for me to try to not send somebody to the hospital. And again, I work really hard not to send people to the hospital. What that has meant for me in my own practice is I have had to get more comfortable with risk and risk management. And, I'm happy to say that in a 28-year career, I have only needed to hospitalize somebody once. And when I did do it, I went with them to the hospital. And I think that's another thing that we need to think about. If you are going to send someone to the hospital, at the very least, don't send them by themselves with strangers, right? And again, I get that is complicated, especially if you've got other clients to see that day. Because if you're going to go to the hospital with your client, you're going to sit in the emergency room for a good 6 hours, right? Um, and the other thing that is true about that hospitalization is it was voluntary. I did not send someone to the hospital who didn't want to go, right? So we had gotten to a point where they wanted to go, but the only way they would go voluntarily is if I went with them. And I did. And, what I did is I canceled the rest of my clients for the rest of the day, which, that's a choice. And that's also not a choice everybody gets to make. But that's also the system, right? The reason why people can't make those choices is that we don't have real systems of care in this country. We have real systems of, managed care in this system, whereby we can only do what's going to be covered by insurance, which may not actually be good care.
So do you find that some of your colleagues here in the States are also exploring these kinds of options? I mean, you mentioned risk management, and that's a huge part of it. I cannot wrap my mind around every professional that we consider under the umbrella of human services to have the time, the resources, the initiative to go in this direction. But do you see at least a start with amongst the people that you work with?
I would say that, again, what I said from the outset is that suicide is still a pretty big taboo in our culture. It's even a taboo in our professions. So there's been over 2 decades worth of research indicating that most people who are human services professionals never got formally trained in suicide assessment, intervention, or prevention. And that's across psychology, social work, nursing, etc. So, from my perspective, I don't know how professions who see most of the people who are suicidal in this country, how we all are also the people who are not getting trained in suicide prevention, assessment, and intervention. So if it were me and I was the benevolent dictator of human services education, I would first and foremost mandate coursework at the undergraduate and graduate levels in suicide prevention, assessment, and intervention. And again, we should be doing that across the board, regardless of profession, whether you're an undergraduate or graduate, because the truth of the matter is undergraduates in their internships could just as easily come across a client who is suicidal. At the very least, they need to know enough to know who to refer to, right? To know what resources exist in the community that might be needed in order to better help somebody. So that's where I would start, is just at the educational level in this country, mandating that suicide prevention, assessment, and intervention work be integrated into all undergraduate and graduate human services professional programs. Then it also starts in our continuing education, right? Um, Again, every state kind of has its own standards, but there are only about 10 states in the United States that, as part of their continuing education requirements, require any sort of suicide intervention or prevention hours. Um, that's not a lot. And again, suicide is pretty ubiquitous. Like every single day we're hearing about a new group of people who's at risk. Farmers, construction workers, dentists. Like, it's becoming so ubiquitous that I actually tell my students, if you are human, you are at risk for suicide. Because the truth is under the right circumstances, in the right context, any one of us could be vulnerable to suicidality. So I would also like us to kind of do universal screenings for suicide. So regardless of why you're going to the hospital, no matter whether you're doing your annual physical or you're being seen in the emergency room or you're just seeing your cardiologist for your routine echocardiogram, like anytime you are interfacing with a professional in human services, again, as we broadly define that, we should be doing suicide screenings. So I would start there. God, I mean, what I'm talking about in terms of suicide sanctuaries and like that's several decades down the road. Like, we actually have to change the culture first, starting with our own professions and then working to the broader culture.
Yeah. Yeah, that's a lot to deliver. And I see it all the time when it comes to this inner reflection of the way we already do stuff in this field, whatever the profession might be that we consider under the umbrella. We have a big task ahead of us to set new standards, not just for mental health, professionals and nurses and those that are like directly involved with people's livelihoods, but everything else. Like that's a big task to cover, but no one's out here trying to do it all in one day. Like, we know better than that, right? But like you said, the experience of those who face suicidality and the mindsets that we have in our culture, like, that's a good place to start, like with the individual. So there's like this working of bottom down and top up with, or bottom up and then top down, with kind of readjusting, unlearning, relearning, which I see as a pattern a lot. Like, we have to go both directions to kind of, unravel the things that we have gripped so tightly to, especially theoretically, because our practices tend to kind of Wild West themselves, while our theories have stayed so concrete. Kind of rounding out what you've been saying, what advice would you give to students that are interested in tackling this kind of issue? And also, anything you would suggest to the professionals that you work with or that are would like to make an impact in this kind of issue that people have?
So I think first and foremost, I think we should just be having more conversations about suicide. It's interesting when I have spoken to colleagues who teach in other programs, even in social work, and I ask them, why don't you guys offer a course in, suicide prevention? The the most often response that I get is we're uncomfortable. And what's interesting about that is like the only way we become comfortable is to talk about it more, right? I mean, in the same way when we work with clients who are experiencing taboos in their own lives, whether it's, incest or domestic violence or substance abuse, like we know that when people have the opportunity to talk about it more frequently, people become more comfortable. And the more comfortable we become with it, the more that it becomes possible to actually address a problem, right? And just even in the area of suicide, we know this from the research. So if you look at 988, which is the National Suicide and Crisis Hotline that came out a couple of years ago, if you look at the data in terms of when somebody calls, what level of suicide risk are they at? And then what suicide risk are they at the end of that 15 or 20-minute phone call? You see a massive reduction in suicidality. So you can have people who are calling, who are, on a scale from 0 to 10, 10 being, I'm going to end my life right now, 0, not at all. Most people who call are somewhere between a 7 and a 10. But the research is pretty clear that somewhere between 80 and 90% of people who call 988, by the end of that 15 to 20-minute phone call, they're at a place where they don't need anything else, right? That to me is an indicator of if we just create spaces to talk about this more, our discomfort goes away. And once the discomfort goes away, then we can start brainstorming creative solutions, right? That are more bottom up. Like if we allow people who are suicidal to come out of the shadows and we create spaces for them. We get not just give them seats at the table, but we actually help create the table with them where they have real power and decision-making power. Like, who knows what kind of really creative solutions we could come up with. But we're sidelining a lot of that knowledge by excluding people, by only primarily listening to mostly people who have never been suicidal in their life, but have PhDs and have been studying it second and third hand. So I think that's, if I was to encourage students and colleagues, it would be, let's have more open and honest conversations about suicide. Let's have more open and honest conversations about the limits of our codes of ethics and how that might be actually getting in the way. Let's have open and honest conversations about what's really happening in hospital emergency rooms. And I will say, if you talk to most hospital emergency rooms, they would love suicidality to be taken out of their hands. It's just we don't have another space. We've not created another space in our culture for people who are suicidal. So that's where I would start. I would, if you are interested in this topic, start asking your professors, start asking program coordinators, start asking your internships, can we have some conversations about this? And what are we doing? Looking at your own agency policies around how suicide is addressed, I think is also another really concrete and very doable step.
Isn't it fascinating how that practice and that manifold of creating spaces where people can feel comfortable opening up about themselves is essentially the backbone of, therapeutic treatments, whether it's holistic or not. We have full capacity. Like, we know how to do that. We have the tools, we have the blueprint. So I'm hopeful in that regard because we've done it before. I think it's just, with the experience of being human, we only learn best, as animals through the experience. A lot is lost because of that, that grow and become and understand the world as a whole and problems like this. But at the very least, we know we can do it. And I think that that leads to a lot of grassroots movements, a lot of people that are just fed up with the way things already are. And so that becomes like a bottom-up situation. And I very much appreciate, even as someone who has the credentials, as many as you have, and the time you've dedicated to learning the theories, and also moving into qualitative research, which is one of my favorite aspects of what we do in academics, that you are pointing out, like, this is half of the journey. The other half is going to include those who not just have experienced it, but are currently living that. And that is, like we both agree, a lot. It goes against like major cultural beliefs. But for me, my brain says, whatever, like it does. And yet we have to, and not everyone that is an enthusiast in any regard in anything is going to agree with somebody else. And just, in suicide prevention and just the understanding of suicidality, I'm sure there's going to be those who are currently experiencing and who are going to butt heads about how this should be approached. So it's not like everyone's going to be inclusive in that experience. But what you're saying is definitely, it's true that we have the tools and capacity and at least the credentials, right? The access to those experiencing this to make a change. And I'm so very happy and very proud that there are, individuals like yourself, advocates like yourself, who see that and say, hey, over here, like, let's piece these things together just in a different arrangement. And let's include those who are most affected by it, because their voices are going to make the biggest change, right? I very much appreciate you coming on and exploring this topic with me. There's going to be a lot of feedback. I know people wanting to hear more. So I hope you would love to come back and have this similar conversation again in the future.
Thank you for your time, and thanks for the invitation.
Special thanks to our guest, Dr. Heath Hightower. Be sure to register on our website for Dr. Hightower's professional development webinar, Reimagining Suicide Prevention, on September 24th. Are you or someone you know interested in joining us at the roundtable? Let's talk about it. Connect with the team at info@nationalhumanservices.org. You can find all our roundtable conversations on YouTube, Spotify, Apple Podcasts, and the iHeartRadio app. Be sure to follow us on social media and check out our website for everything NOHS.